And now it's time for Crohn's disease. Pathophysiology review. Crohn's disease is a chronic inflammatory disease of the small intestine, most often, the colon, or both. It can affect the GI tract from the mouth to the anus, but most commonly affects the terminal ileum. CD presents as inflammation that causes a thickened bowel wall, strictures and deep ulcerations, cobblestone appearance, that is called cobblestone appearance, also occur, which put the patient at risk for developing a bowel fistula, abnormal opening tract between two organs or structures. The result is severe diarrhea and malabsorption of vital nutrients. Anemia is common, usually from iron deficiency or malabsorption issues. Patient-centered care, genetic genomic considerations. The exact cause of CD is unknown. So remember, every time I mention CD means Crohn's disease. A combination of genetic, immune, and environmental factors may contribute to its development. About 20% of patients have a positive family history for the disease. The discovery of a mutation of the NOD2 CARD15 gene on chromosome 16 seems to be associated with some patients who have CD. This gene is found in monocytes that normally recognize and destroy bacteria. Other risk factors include tobacco use, Jewish ethnicity is the same as in ulcerative colitis, and living in urban areas is more common in individuals of Ashkenazi Jewish background than in any other group. Current research has found genetic markers in this population that contribute to higher rates of CD. It was once thought that stress and nutrition play a role in the development of CD, but these factors have not been proven. However, inadequate nutrition can exacerbate the patient's symptoms. Assessment: how we recognize the cues. Crohn's disease can be exacerbated by bacterial infection. Ask about recent unintentional weight loss, the frequency and consistency of stools, the presence of blood in the stool, fever, and abdominal pain. When inspecting the abdomen, assess for distension, masses, or visible peristalsis. Inspection of the perineal area may reveal ulcerations, fissures, or fistula. Okay. During auscultation, vowel sounds may be decreased or absent with severe inflammation or obstruction. An increasing high pitch or rushing sound may present over areas of narrow bowel loops. Muscle guarding, masses, rigidity, or tenderness may be noted on palpation by the primary healthcare provider. Look at that enteric between intestine and intestine. External enterocutaneous between skin and intestine. Very interesting. Types of fistulas that are complications for Crohn's disease. Most patients report diarrhea, abdominal pain, and low-grade fever. Fever is common with fistulas, abscesses, and severe inflammation. Abdominal pain from inflammation is usually constant and often located in the right lower quadrant. Right lower quadrant. Right lower quadrant, remember, is the same place where appendicitis happens. Okay. Also, Patients with Crohn's, besides having weight loss, are having fluid and electrolyte balance and vital nutrient deficiencies. Clinical depression and severe anxiety disorders are common among patients with CD. Yeah, of course, this disorder is very stressful. Nursing safety priority. For the patient with Crohn's disease, be especially alert for signs and symptoms of peritonitis, discussed earlier on this chapter, a small bowel obstruction, and nutrition and fluid imbalances. This keeps repeating in most of the disorders related to the gastrointestinal disease. Early detection of a change in the patient status helps reduce these life-threatening complications. Anemia is common as a result of slow bleeding and poor nutrition. Serum levels of folic acid and vitamin B12 are generally low because of malabsorption, further contributing to anemia. Amino acid malabsorption and protein-losing enteropathy may result in decreased albumin levels. C-reactive protein and ESR may be elevated to indicate inflammation. White blood cells in the urine may show infection pyuria. X-rays show the narrowing ulcerations, strictures, and fistulas common with Crohn's disease. Magnetic resonance enterography is performed to determine bowel activity and motility. So what are the interventions? The non-surgical management. Drugs used to manage Crohn's disease are similar to those used in the treatment of ulcerative colitis. Two agents that may be prescribed for CD are azathioprine and mercaptopurine. These drugs suppress the immune system and can lead to serious infections. Methotrexate may also be given to suppress immune activity of the disease. And this methotrexate is a chemotherapy. It's the same medication they use for rheumatoid arthritis. Basically, it's an immune suppressor, right? So it's given in all these diseases that has hyperactivity of the immune system. So, as we know, it's not only targeting the hyperactivity action of the immune system, but also targeting the cells and the participants that protects the immune system, right? So the good and bad cells. Drug alert, nursing safety priority, both infliximab and certolizumab Pigol must be given in a healthcare setting, such as a medical office, via parental routes. Teach patients how to give themselves a subcutaneous injections for those drugs that come in that form. Natalizumab is given IV under medical supervision every 4 weeks for moderate to severe Crohn's disease and when other drugs are not effective. Although glucocorticoids can be effective for patients with CD, sepsis can result from abscess or fistulas that may be present. These drugs mask the symptom of infection. We know that. Cipro, fluoxetine, and metronidazole may be helpful in patients with fistula and rectal abscesses and infection related to CD. Nutrition therapy. Long-standing nutritional deficits can have severe consequences for the patient with Crohn's disease. Poor nutrition can lead to inadequate fistula and wound healing, loss of lean muscle mass, decreased immune responses, and increased morbidity and mortality. I just want to say something at this point related to this IBD disorders, the ulcerative colitis and the Crohn's disease, and the number of medications patients are getting. For you as a nursing student, it's good to know, don't feel overwhelmed with the amount of medications and the names and the actions and the side effects. When the time comes and you have to work with this type of patient, you will be mastering the side effects, right? In terms of NCLEX, what you really need to know is basically the most important medications, the most used. I would say methotrexate, ciprofloxacin, I would say metronidazole, the most well-known medications and the side effects. Okay, there are many new therapies that are coming out, and it's impossible that you cover most of them. As long as you know they are immunotherapies and they affect the immune system and they mask infections, it's good. It's well enough. Okay, focus on how to protect the patient from infections and how to monitor if there is hemorrhage or fever or any other side effects. But don't get too deep into these medications now, because when the time comes, if you are working in this area, in this particular area, let's say you become a nurse in a gastrointestinal environment, with a gastroenterologist, then you're going to learn more and more about these medications. Okay. Um, just in general, select the ones that are more important, the most well known. Okay. Um, the patient. Okay. Nutrition therapy. Long-standing nutritional deficits can have severe consequences for the patient with Crohn's disease. Poor nutrition can lead to inadequate fistula and wound healing. Yes. Loss of lean muscle mass, decreased immune responses, and increased morbidity and mortality. The patient may be hospitalized to provide bowel rest and nutritional support with total parental nutrition. Nutritional supplements such as Ensure or Sustacal can be given to provide nutrients and more calories. Teach the patient to avoid GI stimulants such as caffeinated beverage and alcohol. Um, Fistula management. The patient with multiple fistulas often has complications such as systemic infection, skin problems including abscesses and fissures, and malnutrition. Treatment of the patient with an abscess, a localized infection in which there is a collection of pus, requires an incision and drainage, IND, local procedure. Management of the patient with a fistula is more complicated and includes nutrition and electrolyte therapy, skincare, and prevention of infection. Nursing safety priority, adequate nutrition and fluid and electrolyte balance are priorities in the care of the patient with a fistula. Is the same with many conditions in the gastrointestinal. GI secretions are high in volume and rich in electrolytes and enzymes. The patient is at high risk for malnutrition, dehydration, and hypokalemia, decreased serum potassium. Assess for these complications. Careful monitor urinary output and daily weight. The patient requires at least 3,000 calories daily to promote healing of the fistula. If he or she cannot take adequate oral fluids and nutrients, total parental nutrition, total enteral nutrition, or TPN may be prescribed. Okay. Another safety priority for patients with fistulas. Preserving and protecting the skin are the nursing priorities. Yes. Be sure that wound drainage is not in direct contact with the skin because intestinal fluid enzymes are caustic, are corrosive, right? Clean the skin promptly to prevent skin breakdown or fungal infections, which can cause major discomfort for the patient. And that is these fluids are having a very high pH, so that's why they are corrosive. Patients, they are very acidic. Patients with fistula are also at high risk for intra-abdominal abscesses and sepsis. Antibiotic therapy is commonly prescribed, observed for signs of sepsis, systemic infections such as fever, abdominal pain, or a change in mental status. Other helpful interventions for the patient with CD are those that relax the patient and soothe the GI tract. Such therapies may include naturopathy, herbs like ginger, acupuncture, hypnotherapy, and Ayurveda, a combination of diet, herbs, yoga, and breathing exercises. Um, Here there is a structuroplasty may be performed for bowel strictures related to Crohn's disease. This procedure increases the bowel diameter. And here we have skin barriers such as wafers A are cut in fit half inch around the fistula. A drainable pouch B is applied over the wafer and clamped until the pouch is to be empty. Effluent should drain into the bag and not in contact to the skin. B is the one that I've worked the most frequently. B. Okay. Self-management education. Nutrition. Teach the patient and family to make arrangements for the patient to have easy access to the bathroom and privacy to perform fistula care if needed, similar to ulcerative colitis. Provide health teaching for drug therapy, including purpose, dose, and side effects, in addition to other drugs. Vitamin supplements, including monthly vitamin B12 injections, may be needed because of the inability of the ileum to absorb certain nutrients. In collaboration with the dietitian, instruct the patient to follow a low residue, high calorie diet and to avoid foods that cause discomfort such as milk, gluten, and other GI stimulants like caffeine. Recommend stress management techniques, counseling, physical therapy to improve quality of life. If a patient has a fistula, explain and demonstrate wound care. Patients who are discharged to home after undergoing resection and anastomosis may require visits from a home care nurse to assess the surgical wound and monitor for complications. In collaboration with the care manager, assist with obtaining the equipment and supplies for fistula care, such as skin barriers and wound drainage bags. Okay, and with this, we have completed our Crohn's disease.